Hello and welcome to the Point of Care podcast. Today's episode is a full clinical review on atrial fibrillation. If you'd like to follow along with our online clinical review article, you can find the link in the show notes. Let's start with a few key takeaways. Atrial fibrillation, or AFib, is the most common sustained heart arrhythmia. In the US, it affects about 10.55 million adults. It's characterized by rapid, disorganized electrical signals in the atria, which leads to an irregular heart rhythm. AFib significantly increases the risk of stroke, heart failure, myocardial infarction, dementia, chronic kidney disease, and even mortality. Patients can be asymptomatic, which occurs in about 10 to 40% of cases. When symptoms are present, they include palpitations, shortness of breath, chest pain, and fatigue. Management focuses on preventing stroke through anticoagulation, controlling the rate or rhythm, and addressing any modifiable risk factors. Early rhythm control using antiarrhythmic medications or catheter ablation can be beneficial, especially for those with symptomatic paroxysmal AFib or heart failure with reduced ejection fraction, also known as HFrEF. Let's clarify a few definitions. In 2023, the ACC, AHA, ACCP, and HRS guideline writing group proposed 4 stages of AFib evolution. Stage 1 is at risk. These are patients with AFib-associated risk factors like obesity or hypertension. Stage 2 is pre-AFib. This involves signs of atrial pathology on an electrocardiogram or imaging, but without actual AFib. Stage 3 is AFib itself. This is the presence of paroxysmal, meaning less than or equal to 7 days, or persistent, which is greater than 7 days, AFib subtypes. Stage 4 is permanent AFib. This is when AFib is established and rhythm control is no longer pursued. Now let's talk about valvular AFib. The definition has changed over time. The key distinction is moderate to severe mitral stenosis or mechanical heart valves. These are the primary drivers of thromboembolic risk. Warfarin is preferred for anticoagulation in these patients. Next, let's discuss etiologies. The development of AFib is multifactorial. It involves both modifiable and non-modifiable risk factors. Age is the strongest risk factor, with incidence increasing significantly after age 65. In the Framingham Heart Study, the incidence per 1,000 person years increased from 3.7 to 13.4 in men and 2.5 to 8.6 in women over 50 years. The lifetime risk of developing AFib for individuals over 40 years old is approximately 1 in 4. Cardiovascular conditions like hypertension, heart failure, coronary artery disease, valvular heart disease, especially mitral valve disease, and cardiomyopathies significantly increase AFib risk. Other comorbidities such as diabetes, obesity, obstructive sleep apnea, chronic kidney disease, and hyperthyroidism are strongly associated with AFib development. Lifestyle factors like excessive alcohol consumption, that's more than 1 standard drink daily or binge drinking, smoking, and physical inactivity contribute to AFib risk. Paradoxically, male endurance athletes have a higher AFib risk. This is despite exercise generally being protective. Holiday heart syndrome is an irregular heartbeat like AFib triggered by excessive alcohol. However, it can be triggered by moderate alcohol, stress, dehydration, or lack of sleep. Genetic factors also play a role. Family history increases risk. Genetic variants affect approximately 30% of AFib risk. Compared with individuals in the lower third of both clinical and polygenic risk, those in the upper third have more than double the lifetime risk of AFib at 48.2% versus 22.3%. Finally, acute medical conditions like sepsis, surgery, and other acute illnesses can trigger new onset AFib. 42 to 68% of these patients experience recurrence within 5 years. You can use the mnemonic H-Pirates or parasite to remember common causes of AFib. The pathophysiology of AFib involves complex interactions between triggering mechanisms and an abnormal atrial substrate that sustains the arrhythmia. Triggers are ectopic atrial premature beats that initiate AFib. They typically arise from myocardial sleeves extending from the pulmonary vein atrial junction into the pulmonary veins. These ectopic foci can spark AFib episodes when encountering vulnerable atrial tissue. In those with structurally normal hearts, mostly paroxysmal AFib, episodes are triggered by premature atrial complexes, particularly those originating near the pulmonary veins. Substrate development involves disease-specific atrial electrophysiologic, structural, and histopathologic changes. This creates a substrate that promotes electrical re-entry and AFib persistence. For example, atrial fibrosis and hypertrophy. Hypertension activates the renin-angiotensin-aldosterone system, inducing atrial fibrosis and hypertrophy. This slows atrial conduction and promotes re-entry. Oxidative stress and inflammation. Obesity increases oxidative stress, systemic inflammation, and abnormal calcium cycling, increasing atrial ectopy and promoting arrhythmia maintenance. Autonomic dysfunction. Conditions like sleep apnea alter atrial repolarization through autonomic dysfunction, creating a favorable environment for AFib. AFib-induced remodeling. Once established, AFib itself causes additional electrical and structural remodeling. This makes the arrhythmia more persistent and difficult to treat, hence the saying, AFib begets AFib. Electrophysiological changes can occur within hours of AFib onset, which is electrical remodeling. Structural remodeling, like fibrosis and dilatation, develops over months. Finally, there's a bidirectional relationship with heart failure. AFib and heart failure frequently coexist and predispose to each other. This creates a vicious cycle. In patients with AFib and newly diagnosed HFrEF, tachycardia-mediated cardiomyopathy should be considered when common etiologies have been excluded. This brings us to the signs and symptoms. Atrial fibrillation presents with varying symptoms. It's important to note that about 10 to 40% of patients are asymptomatic. Common symptoms include palpitations, which are a sensation of a rapid heartbeat, dyspnea or shortness of breath, especially with exertion, chest discomfort or pain, fatigue, presyncope or lightheadedness, and reduced exercise tolerance. An asymptomatic presentation is more common in men, with 10% asymptomatic versus 3% in women. It's also more common in older adults, with a mean age of 74 versus 62 years for symptomatic patients, and in those with diabetes. It's often discovered during evaluation of complications like stroke or heart failure, or incidentally during routine examinations. Physical exam findings may include an irregularly irregular pulse, variable first heart sound intensity, and absence of an A waves and jugular venous pulsations. There's also the apex pulse deficit, which is the difference between the apical and radial pulse counted over 1 minute. A deficit of 10 or more is indicative of AFib. This is due to inadequate left ventricular filling and stroke volume. It has a sensitivity of 62.8% and a specificity of 85.7%. You may also see signs of underlying causes like mitral valve disease or thyroid abnormalities and signs of complications such as heart failure. In patients presenting with stroke or infarction, the brain, kidneys, and spleen are the most likely targets of emboli and AFib. Now let's talk about the diagnostic workup. Diagnosis of atrial fibrillation is based on electrocardiographic documentation and appropriate clinical evaluation. First, electrocardiographic confirmation is key. A 12-lead EKG will show irregular atrial activity, which are fibrillatory waves without discrete P waves. You'll want to make sure it's actually AFib and not just sinus rhythm with lots of premature atrial complexes. Look for the P waves. An episode lasting greater than 30 seconds on a rhythm strip or continuous monitoring is also required. Classification is based on the pattern. Paroxysmal, which is less than or equal to 7 days, persistent, which is greater than 7 days or requiring cardioversion, long-standing persistent, which is greater than 1 year, or permanent, which is a decision made not to pursue rhythm control. A basic evaluation should include a complete history and physical examination. This assesses symptoms, risk factor, and complications. A transthoracic echocardiogram assesses cardiac structure, atrial size, valvular disease, and ventricular function. Laboratory testing should include a complete blood count, a comprehensive metabolic panel, and thyroid function tests. Additional tests can be performed based on clinical suspicion. Extended monitoring is used for suspected but undiagnosed AFib. This can include Holter monitors for 24 to 48 hours, event recorders or mobile telemetry for up to 30 days, and implantable loop recorders for up to 4 years. These are particularly useful after cryptogenic stroke. Wearable consumer devices may detect possible AFib, but require confirmation with a standard EKG. Additional testing may be indicated. A transesophageal echocardiograph, or TEE, can exclude a left atrial appendage thrombus before cardioversion. A cardiac CT or MRI can assess pulmonary vein anatomy before ablation or to assess for structural heart disease. Exercise testing is only done when there are specific indications, such as in suspected ischemia. Now let's discuss treatment. Management of atrial fibrillation follows a comprehensive approach. This targets stroke prevention, symptom control, and addressing underlying risk factors. First, stroke prevention. Anticoagulation is recommended for patients with an estimated stroke or thromboembolic risk of greater than or equal to 2% per year. Generally, this is a CHADS-VASc score of greater than or equal to 2 for men and greater than or equal to 3 for women. To calculate the CHADS-VASc score, congestive heart failure is 1 point, hypertension is 1 point, age greater than or equal to 75 is 2 points, diabetes is 1 point, stroke or TIA history is 2 points, vascular disease is 1 point, age 65 to 74 is 1 point, and finally, the sex category of female is 1 point. Bleeding risk scores, like has bled, should not be used in isolation to determine eligibility for oral anticoagulation. Instead, it should be used to identify and modify bleeding risk factors and to inform medical decision-making in patients deemed at a high risk for stroke. Direct oral anticoagulants, or DOACs, are first line for non-valvular AFib. Apixaban is dosed at 5 milligrams twice daily. The dose is 2.5 milligrams twice daily if the patient has greater than or equal to 2 of the following: age greater than or equal to 80, weight less than or equal to 60 kilograms, or a serum creatinine greater than or equal to 1.5. Apixaban is usually the best choice for chronic kidney disease or end-stage renal disease. Rivaroxaban is dosed at 20 milligrams daily with food. The dose is 15 milligrams daily if the creatinine clearance is 15 to 50. Edoxaban is dosed at 60 milligrams daily. The dose is 30 milligrams daily if the creatinine clearance is 15 to 50, and the weight is less than or equal to 60 kilograms. Dabigatran is dosed at 150 milligrams twice daily. Warfarin, with a target INR of 2 to 3, is indicated for moderate to severe mitral stenosis, mechanical heart valves, and patients with a creatinine clearance of less than 15 milliliters per minute who cannot take apixaban. Left atrial appendage occlusion or closure, using devices like Watchman or Amulet, may be considered for patients with contraindications to long-term anticoagulation. However, patients will often still need to be on anticoagulation for a period of time after the device is placed. Antiplatelet therapy alone, like aspirin, is not recommended for most patients for stroke prevention in AFib due to inferior efficacy. In patients with coronary artery disease or acute coronary syndrome after PCI, discontinue aspirin early, after about 1 to 4 weeks after PCI, and continue anticoagulation plus a P2 Y12 inhibitor instead of triple antithrombotic therapy. AFib burden, meaning the duration and frequency of episodes, is associated with the risk of thromboembolic events. This is independent of CHADS-VASc. AFib episodes lasting longer than 17 to 24 hours impart significant risk. There may be a greater than 2-fold increase in stroke risk for AFib duration greater than or equal to 1 hour compared with shorter durations. However, there are no clear thresholds, and AFib episodes and strokes are not always temporally associated, but stroke risk is higher during the 5 days immediately after an episode of AFib. Finally, atrial high-rate episodes are associated with an increased risk of stroke and may be precursors to the development of AFib, warranting initiation of anticoagulation. Let's move on to rate control strategies. The RACE-2 trial established a goal heart rate of less than 110 beats per minute for rate control. However, in patients with left ventricular dysfunction or persistent symptoms, a heart rate of less than 80 is generally preferred. In critically ill patients with AFib, there's usually a more permissive heart rate, as quickly pushing the heart rate to less than 100 without breaking the rhythm can be dangerous. First-line agents include beta blockers like metoprolol, dosed at 25 to 100 milligrams twice daily, atenolol, dosed at 25 to 100 milligrams daily, or bisoprolol, dosed at 2.5 to 10 milligrams daily. Beta blockers are favored in hyperthyroidism. Non-dihydropyridine calcium channel blockers like diltiazem, dosed at 120 to 360 milligrams daily, or verapamil, dosed at 120 to 360 milligrams daily. Recent guidelines give a strong recommendation against using IV non-dihydropyridine calcium channel blockers in patients with AFib with RVR and known moderate or severe left ventricular systolic dysfunction, with or without decompensated heart failure. Second-line agents include digoxin, dosed at 0.125 to 0.25 milligrams daily. It's particularly useful in heart failure patients or as an adjunctive therapy, but it's not for acute management as it takes 2 hours for onset. Amiodarone can be used for rate control when other agents fail. Procainamide is generally preferred for patients with pre-excitation, like in Wolff-Parkinson-White syndrome. In such cases, AV nodal blocking agents are contraindicated as they can precipitate ventricular tachycardia or ventricular fibrillation. Finally, AV node ablation with pacemaker implantation can be considered for patients with inadequate rate control despite optimal medical therapy. Now let's talk about rhythm control strategies. The EAST-AF-NET trial showed some benefit for early rhythm control, though with a high number needed to treat of 333 for combined outcomes. In general, everyone with new AFib deserves an early attempt at sinus rhythm, either through chemical or electrical cardioversion. However, certain populations likely benefit the most from this. Indications for rhythm control include symptomatic AFib despite adequate rate control, the first episode of AFib, AFib with heart failure, especially HFrEF, young patients, athletes, and a patient preference for rhythm control. Cardioversion options include electrical cardioversion. This is a synchronized direct current shock that requires sedation. Use antero-posterior pad placement, meaning the left parasternal region and the left scapular region. Synchronize to the QRS and never defibrillate. You can start with 100 joules biphasic. Pharmacologic cardioversion can be achieved with classic 1C agents like flecainide or propafenone for patients without structural heart disease, or class 3 agents like amiodarone, dofetilide, or ibutylide. Short AFib duration and normal left atrial size are predictors of successful cardioversion. The use of antiarrhythmic drugs prior to and after shock delivery may increase the likelihood of success. Do not initiate antiarrhythmic drug therapy in patients with advanced conduction disturbances unless anti-bradycardia pacing, like a pacemaker, is provided. Maintenance of sinus rhythm can be achieved with antiarrhythmic drugs. Class 1C agents like flecainide, dosed at 50 to 200 milligrams twice daily, or propafenone, dosed at 150 to 300 milligrams 3 times daily. Avoid these in coronary artery disease and structural heart disease. They can be used in a pill-in-pocket approach for patient-led cardioversion. This is best for recent onset, infrequent episodes, and no structural or ischemic heart disease. Class 3 agents like amiodarone, dosed at 200 milligrams daily, sotalol, dosed at 80 to 160 milligrams twice daily, dofetilide, dosed at 125 to 500 micrograms twice daily, and dronedarone, dosed at 400 milligrams twice daily. Catheter ablation involving pulmonary vein isolation to eliminate triggers is particularly effective for paroxysmal AFib, with a 70 to 80% success rate, patients with heart failure, as it improves outcomes, young patients with symptomatic AFib, and those with AFib refractory to antiarrhythmic drugs. Anticoagulation after ablation is based on the CHADS-VASc score and not on the underlying rhythm. Let's talk about risk factor modification. Weight management is important. Aim for greater than or equal to 10% weight reduction in overweight or obese patients with a BMI of greater than 27. Exercise with moderate activity for 210 or more minutes weekly or 30 minutes daily is helpful, except in cases of AFib due to excess training. Blood pressure control with a target of less than 130 over 80 millimeters of mercury is beneficial. Management of sleep apnea using CPAP therapy when indicated is also helpful. Alcohol reduction or elimination is particularly important for rhythm control. Reduce consumption to less than 3 standard drinks per week. Smoking cessation with comprehensive support for tobacco cessation should be encouraged. Glycemic control with optimal diabetes management is also key. Caffeine abstinence is not advised to prevent AFib unless the patient feels that it exacerbates their symptoms. Let's move on to some clinical pearls. Let's start with epidemiology and general information pearls. Atrial fibrillation affects up to 1 in 3 people in their lifetime. As of 2019, approximately 10.55 million adults in the US were affected. The lifetime risk is significantly influenced by both clinical risk factors and genetics. Those in the highest risk category have a greater than 40% lifetime risk. Prevalence is higher in men, about 28 million worldwide, compared to women, about 25 million worldwide. 10 to 40% of patients with AFib are asymptomatic, with asymptomatic presentation being more common in men and older adults. New onset AFib that occurs when patients are hospitalized or post-operatively shouldn't be given a free pass. These patients are now known to be at risk for recurrent AFib and embolic events. And finally, there's increasing identification of AFib via patient-initiated monitoring, like with Apple Watches. Next, let's discuss pathophysiology pearls. Ectopic atrial beats that initiate AFib typically arise from myocardial sleeves extending from the pulmonary vein atrial junction. Ventricular rate variability depends on the speed of AV node conduction. Younger patients can be more symptomatic and tachycardic. AFib typically begins as paroxysmal episodes but can progress to persistent and permanent forms due to progressive atrial remodeling. This is often described as AFib begets AFib. Atrial high rate episodes lasting greater than 6 minutes detected on cardiac implantable electronic devices are associated with a 2.4-fold increased stroke risk. The probability of detecting AFib increases with the duration of monitoring, making prolonged monitoring crucial in cases like cryptogenic stroke. And finally, remember that AFib is distinct from multifocal atrial tachycardia. Moving on to etiology and risk factor pearls. Approximately 15% of individuals who develop AFib have no identifiable risk factors. Taller height is independently associated with increased AFib risk, possibly due to larger atrial size. Vagally mediated AFib commonly occurs at night or in the early morning when vagal tone is normally predominant. Male endurance athletes have higher AFib risk despite physical activity typically being associated with lower risk in the general population. New onset AFib during hospitalization for non-cardiac illness has 5-year occurrence rates of 42 to 68% and is associated with increased stroke and mortality risk. Paroxysmal AFib recurrence is common, ranging from 70% at 1 year without antiarrhythmic therapy to 60 to 90% at 4 to 6 years. The rates of progression from paroxysmal AFib to persistent AFib are 8%, 12%, 18%, and 25% at 1, 2, 4, and 5 years respectively. Younger age, lower rates of hypertension and heart failure, smaller left atrial diameter, and preserved left ventricular systolic function are all associated with a lower risk of progression to persistent AFib. Sodium glucose cotransporter 2, or SGLT2 inhibitors, are associated with reduced AFib risk with a relative risk of 0.82 in patients with diabetes, heart failure, or kidney disease. That brings us to clinical presentation and diagnosis pearls. AFib diagnosis requires ECG documentation of irregular activity without discrete P waves lasting greater than 30 seconds. The true prevalence of paroxysmal AFib may be underestimated due to asymptomatic episodes, even those lasting greater than 48 hours. The duration of recurrent AFib episodes vary over time in each individual, and progression to persistent or permanent AFib is common. The LOOP study found that despite increasing AFib detection with implantable loop recorders, 31.8% versus 12.2%, there was no significant reduction in stroke when anticoagulation was instituted. Consumer wearable devices like smartwatches have relatively low positive predictive value for AFib. In the Apple Heart study, only 34% of notifications were subsequently confirmed as AFib. In AFib with concurrent heart failure, consider tachycardia-mediated cardiomyopathy if common etiologies have been excluded. At very high rates, AFib may appear regular or pseudo-regularization, emphasizing the need to carefully evaluate EKGs at higher heart rates. AFib with rapid ventricular response, or RVR, is more often a consequence of hypotension rather than the cause of it, unless the heart rate is greater than 150. However, AFib can reduce preload via reduced atrial kick, since there's no coordinated P wave. AFib itself can independently elevate D-dimer, troponin, and BNP levels, necessitating careful interpretation in the context of a suspected PE, ACS, or heart failure episode. Rapid ventricular rate in paroxysmal AFib may cause angina and ischemic EKG changes, potentially with troponin elevation, mimicking ACS. Distinguishing between AFib and flutter is not always straightforward. In flutter, the rhythm may be regularly irregular if atrial flutter occurs with a variable AV block occurring in a fixed pattern, like 2-to-1 or 4-to-1. On the other hand, the rhythm may be irregularly irregular with a variable block occurring in a non-fixed pattern. Let's review treatment pearls. Direct oral anticoagulants, or DOACs, reduce the risk of intracranial hemorrhage by approximately 50% when compared to warfarin. CHADS-VASc and AC use in AFib is not really validated in critically ill patients and is a much more nuanced decision based on risks and benefits. Early rhythm control within 1 year of diagnosis reduces cardiovascular outcomes by 21% compared to rate control alone. Get baseline liver function tests, or LFTs, and thyroid function tests, or TFTs, before starting amiodarone. Amiodarone can cause pulmonary fibrosis and can still lead to hypertension initially, especially when bolused. In unstable AFib RVR, the first pressure should generally be phenylephrine, as it avoids adrenergic agonism and can lead to reflex bradycardia. It doesn't make sense to use Levophed, especially if you've previously been giving beta blockers. If starting pressors in a patient with AFib RVR, generally avoid epinephrine and dobutamine, which are beta adrenergic. Catheter ablation is superior to medical therapy for AFib with heart failure, reducing death or heart failure hospitalizations by 38% in the Castle AF trial. Ablation is more effective than antiarrhythmics for maintaining sinus rhythm. Left atrial appendage occlusion requires at least 45 days of anticoagulation, followed by dual antiplatelet therapy for 6 months and lifelong aspirin. Atrial flutter is treated similarly to AFib, but it's tougher to successfully rate control, and it will stay in the 150 beats per minute range, which represents the 2-to-1 transmission through the AV node. You usually need to ablate the cavo-tricuspid isthmus. The most important intervention for critically ill patients with AFib is usually treating the cause or causes of the actual AFib. Finally, let's look at pearls related to complications. AFib is associated with a 2.4-fold increased risk of stroke, a 5-fold increased risk of heart failure, a 1.6-fold increased risk of myocardial infarction, and a 1.5-fold increased all-cause mortality. The left atrial appendage is the source of approximately 90% of thrombi who have CVA with AFib. There's between 1 to 7% chance of stroke with cardioversion if the patient is not anticoagulated. Cardioversion can stun the myocardium and leave the patients prone to clot formation and stroke risk. Anticoagulation is still needed for at least the first 10 days after successful cardioversion. There's no clear endpoint for anticoagulation due to recurrence likelihood being as high as 50% annually. AFib is associated with increased risk of both Alzheimer's disease with an adjusted odds ratio of 1.4 and vascular dementia with an adjusted odds ratio of 1.7, even in stroke-free patients. AFib is independently associated with cognitive decline, with anticoagulation potentially reducing this risk. AFib management and outcomes show significant disparities by sex, race, ethnicity, and social determinants of health, with worse outcomes in disadvantaged populations. Next, I'd like to highlight a few high-yield and most recent review articles. First, there's a JAMA review from 2025 on atrial fibrillation. Next, there's a Kidney International Reports article also from 25 that discusses direct oral anticoagulants, or DOACs, in patients with end-stage renal disease. Finally, the European Heart Journal in 2024 published on catheter ablation for atrial fibrillation, including indications and future perspectives. Those links will be in the show notes. Moving on to clinical trials, let's begin with trials that inform rate and rhythm control strategies. The AFFIRM trial, published in the New England Journal of Medicine in 2002, found that in patients with AFib and risk factors for stroke, a rhythm control strategy involving cardioversion and antiarrhythmic drugs did not reduce mortality compared to a rate control strategy. In fact, it was associated with more hospitalizations and adverse drug effects. The RACE-2 trial, which appeared in the New England Journal of Medicine in 2010, showed that in patients with permanent atrial fibrillation, lenient rate control, aiming for a heart rate less than 110 beats per minute, was non-inferior to strict rate control, targeting a heart rate less than 80 beats per minute. The endpoint was a composite of death from cardiovascular causes, hospitalization for heart failure, stroke, systemic embolism, bleeding, and life-threatening arrhythmic events. Lenient rate control was also easier to achieve. Strict rate control might be better in younger patients and those with heart failure. The EAST-AF-NET 4 trial, published in the New England Journal of Medicine in 2020, demonstrated that in patients with early atrial fibrillation, defined as diagnosed within 1 year, and cardiovascular conditions, early rhythm control therapy using either antiarrhythmics or ablation led to a lower risk of death from cardiovascular causes, stroke, or hospitalization for heart failure or acute coronary syndrome, compared to usual care. Let's shift our focus to trials involving ablation. The CASTLE-AF trial in the New England Journal of Medicine in 2018 showed that in patients with heart failure and atrial fibrillation, catheter ablation led to significantly lower rates of death and hospitalization for worsening heart failure when compared to medical therapy, whether rate or rhythm control. However, the CABANA trial, published in JAMA the next year in 2019, found that in a broad population of atrial fibrillation patients, catheter ablation did not significantly reduce the composite primary endpoint of death, disabling stroke, serious bleeding, or cardiac arrest when compared to conventional medical therapy. It was, however, associated with lower rates of recurrent atrial fibrillation and the secondary endpoint of death or cardiovascular hospitalization. Moving on to anticoagulation trials. The Aristotle trial in the New England Journal of Medicine in 2011 found that patients with AFib and at least one additional risk factor for stroke, apixaban was superior to warfarin in preventing stroke or systemic embolism. It also caused less bleeding and resulted in lower mortality. The ROCKET-AF trial, also in the New England Journal of Medicine in 2011, showed that in patients with non-valvular AFib at moderate to high risk for stroke, the once-daily or oral direct factor 10A inhibitor rivaroxaban was non-inferior to adjusted dose warfarin for the prevention of stroke or systemic embolism when compared to warfarin. Next, let's review trials on antithrombotic therapy in atrial fibrillation patients with coronary artery disease or acute coronary syndrome. The Augustus trial in the New England Journal of Medicine in 2019 showed that in patients with atrial fibrillation who have had an acute coronary syndrome or undergone PCI, apixaban led to less bleeding and fewer hospitalizations compared to vitamin K antagonists, without significant differences in ischemic events. Additionally, omitting aspirin resulted in less bleeding without significant differences in ischemic events when compared to regimens that included aspirin. Finally, the AFIRE trial, also in the New England Journal of Medicine in 2019, demonstrated that in patients with atrial fibrillation and stable coronary artery disease, more than 1 year after revascularization or with angiographically confirmed disease not requiring vascularization, rivaroxaban monotherapy led to fewer cardiovascular events and deaths while causing less bleeding when compared to combination therapy with rivaroxaban plus a single antiplatelet agent. Lastly, here are some other resources you might find helpful. MD-Calc has useful calculators like the CHADS-VASc score, which estimates the 1-year risk of thromboembolic event in a non-anticoagulated patient, and the HAS-BLED score, which estimates the risk of bleeding while on a DOAC. There's also the Curbsider podcast, episode 363, on atrial fibrillation, which discusses rhythm control, catheter ablation, atrial fibrillation in the hospital, and left atrial appendage closure. The UCSF Hospitalist Handbook has a chapter on atrial fibrillation, and the Internet Book of Critical Care has an article on atrial fibrillation and flutter complicating critical illness, which discusses managing atrial fibrillation in an ICU setting with its distinct considerations. That's all for this episode. Check out pointofcaremedicine.com to see the article we discussed and see the pearls, literature, and links to other resources.